It's the first episode of Myonerds podcast. Today we have a special guest, the myth, the legend, Dr. Nick Downey. Welcome, Dr. Nick.
Thank you for having me.
Yeah. Well, as we know, most people use androgens, anabolic steroids, irresponsibly in general. So, the major problem, one of the major problem, as we see, is cholesterol levels. So, the first question is, I want to ask that in practice, which, let's say, what do you think about the most harm? What is the most harmful steroids for lipid profile in general? Let's say, which one do you see
Uh,
that has the biggest impact on HDL and LDL?
it seems to be like any, 17 alpha alkylated steroid or oral steroid, those always seem to skew them the most. Um, just especially ones extensively metabolized by the liver. So I've seen with people using Anavar, they do have skewing, but with Winstrol, that seems to completely destroy HDL and raise LDL through the roof. And I think it's through inhibition of the HMG co-reductase pathway or something like that, where they inhibit that pathway so you don't have as many LDL receptors on the liver, and the liver can't manage,
Yeah, one
your
of the
blood
mechanisms
cholesterol.
is activating the androgen receptor in liver, and also just inhibiting the lipase in liver.
Yeah.
So your LDL
I
count shoots up immediately.
Yeah, it's yeah, exactly. So it's like anything that passes or is extensively metabolized by the liver, which is why even injectable steroids do have a tiny bit of an effect
Yeah,
because all of them do pass through the liver.
correct. So
Yeah.
the, what is the lowest HDL reading you see so far among the
Uh,
among the AAS users?
so it depends what I forgot the units, but I've seen so anything above in South Africa, anything above one is considered normal. I don't know how it is in other countries.
What?
I think they use like 40 or something.
Yeah.
It's like
Anything above 40 is normal in my country.
so I don't know how this converts, but I've seen an HDL of zero point 0.6, which like almost, you know, I mean, not far off
20? Is
being.
it like, can
I
we
think that
equate
would
it to
be around,
20, like
yeah,
half of the
mid
40?
20s. Yeah,
Uh-huh.
mid 20s, and that was, I think, that was after a Winstrol. Winstrol. That's how I know about Winstrol being quite hepatotoxic. I saw that after just a basic test in Winstrol cycle, Winstrol being at 100 a day, though it was titrated up from 50 for 4 weeks and then 100 for 4 weeks, and yeah, that was after the cycle, like after 2 weeks when he was wanted to see how he was doing.
Well,
So yeah,
I'm actually surprised to hear that because I was expecting single digit HDLs. Well, in the blood works I've
I've never
seen
seen that.
the lowest HDL I've seen is 8, literally 8, because of
What
Mistral.
were they using?
Mistral.
How do you get an HDL that low? You must be sitting on a couch and
Well,
going.
probably naturally they have like HDL of high to low 30s probably. So when they use it, they get single digits.
I see. Yeah, I mean, thankfully, I try like anyone who messages me, I do emphasize the importance of cardio and diet and whatnot. Yeah.
And also,
So I've never
it's
seen it
quite.
that.
Sorry for interrupting.
Oh no, no, I was finished.
Well, also we got. It's quite important to address that there's a cumulative effect of health complications when someone develops atherosclerosis. Like there is a synergy of developing atherosclerosis, like 1 + 1 = 3, like having
Yeah.
high angiotensin 2, uncontrolled blood pressure, hyperinsulinemia, like inactivity, many things, hyperlipidemia, high C-reactive protein.
Yeah, I mean, it's it's overwhelming to think about because there are all
Yeah,
these different aspects you have to consider. And I mean, trying to correct each one is quite, time consuming, but I think it's worth it at the end of the day because I mean, it all is, for the most part, you're able to control it. Because even if you have terrible lipids, it's not, although it is necessary, it isn't really like sufficient to cause these heart problems. It's like an amalgamation of different issues, and if you can't control that through, and you've tried everything you can at least try reduce other factors.
yeah.
But it would be best to control your cholesterol, obviously.
Well, how common the uh, like cholesterol medication prescription is in South Africa? I mean, do doctors want to prescribe even when you have like 180, 190 total cholesterol levels, or just they tend to prescribe when you have like sub sub 300s, like borderline 300 or so? What's the preference in
um
general?
so it's actually interesting. We don't have many white patients here, so cholesterol is actually never really that high in African patients, and they seem to never seem to have these issues that white individuals do. But I have come across a few white individuals, and the only time we tend to prescribe the medication is if they have a variety of risk factors, and it's not just the cholesterol. It's when, well, sometimes if the cholesterol's above, I don't. So here we would do it if it was for sure if it was above 8. But I don't know how that translates to like American standards. But um, and then they're not commonly prescribed. They tend to be, the only time I've seen them prescribed is after someone has a heart attack, because part of the management of a heart attack is a statin immediately with it, and then they continue the statin thereafter. I've never really seen it being used preventatively here, but this is in public health, not private. I'm sure private's different.
Yeah, until a year ago, I didn't know that, like in ischemia and reperfusion research, I haven't realized that statins have a really protective effect on cardiomyocytes. Really.
It's like that's why other lipid lowering drugs. What's the name of that one? Is it mitabine or something? It's that one that inhibits absorption in the intestine of
Ezetimibe.
as yes. That's like why it's one of the, although it does have quite potent lowering effects on your cholesterol, it's not necessary. It hasn't really shown to reduce mortality as much as a statin does. And that's because statins have a variety of other effects. They're anti-inflammatory. They stabilize the
Yeah.
plaques that you already have. So they're like, statins are obviously number one if you have these risk factors.
So in your practice, do you see like side effects related to statins? How often do you see like side effects related to statins, especially lipophilic ones? Do you prefer to prescribe less lipophilic ones to someone who had side effects?
So in my limited
Yeah,
exposure to these drugs, I've never seen the reported side effects such as but then again, I was never in a cardio. I'd never really done cardiology or been to the cardiovascular clinic. So I'm sure a lot of people would have come there with the common complaints you get from statins and such. But we always seem to go with atorvastatin initially, and then you always titrate up from there. I have seen simvastatin or atorvastatin, but I think atorvastatin seems to be more favorable.
It's quite available drug wherever you go around the world.
Yeah, I mean, I remember one of our clinical pharmacologists said in one lecture that if they could put statins in the water supply, they would. Just, well, I think he was
Maybe I gotta
about,
disagree with him because I had many musculoskeletal problems, but I'm afraid of having even more. But but I think that they can put like azathimide to waters so everyone can
I mean,
drink.
I'm sure that won't cause much problems if it.
Yeah, gastric stress for a week or two, and probably just 1 or 2% of the population will realize that there's something wrong.
Yeah.
Okay.
Also, that's a pretty expensive water.
Yeah, indeed.
Yeah.
Well, do you think what are the, let's say, uncommon methods of managing the cholesterol in general, also on anabolic cycles? Do you have you experimented on yourself with I don't know, with statins or anything like that to manage your cholesterol values?
So from cholesterol, I used to have quite awful cholesterol values. This was prior to I'll probably do a video or something one day, but it was prior to, sorry, this is kind of promoting my whole plant-based lifestyle, but it was about 6. So the cutoff range here is about 4 for total cholesterol. My LDL was also about 5, and I think 3 is the cutoff. So that was what it was initially, and I drastically reduced that by going plant-based and increasing my fiber intake to approximately 50 grams of fiber a day, 60 grams most days actually. So through
how many kilocalories were you consuming?
So when I eat quite a bit, so that was about 3,500. I was quite skinny back then.
So it was roughly 20 grams per 1,000 kilogram. Is it correct?
Yeah, basically. But even so, individuals who are eating lower, fewer calories should try increase their fiber intake to about 60 or above 30 at least through either supplements or, the fiber supplements. So that was number one. I noticed that helped a lot, and reducing my saturated fat intake to less than 13 grams a day. And people think you're immune to saturated fats if you're on a plant-based diet, but a lot of there's a coconut oil, like I thought it was a healthy oil. That thing is loaded with saturated fats. Any like fast food, junk food has, whether vegan or not vegan, has tons of saturated fat. So those were 2 big things I managed to change, and that reduced it to about 4, which is like the cutoff. And then I was also doing a lot of cardiovascular work. This is before I was into bodybuilding or anything. So it was still high, and it was actually quite high in my family. And the other issue in my family is that we tend to have hypothyroidism. And so hypo, so like we tend to have just higher fasting lipid levels, especially like and when I got onto L-troxin and tertroxin, that drastically reduced it, and now I don't, it's about 2. My total is about 2, and so is my LDL.
You literally halved your cholesterol.
Yeah, that
Yeah.
was, but it's so individual in like dependent. For you have to figure out what's wrong for you, because like I can't say this is gonna work for anyone, because I mean that whole thyroid diagnosis, because I'd never checked it before and I just assumed I was fine, and then my cousin got diagnosed with hypothyroidism. We found out my grand had it, and it was like, yeah, so by solving that, finding an underlying problem, that helped drastically. And then cardiovascular work helps a lot. And then for like guys on cycle, I've noticed quite a few like to use cardarine, although I'm not the biggest fan of it just due to its safety profile. I don't know what
Carcinogen.
you think of it.
Well, it's
Yeah,
a
it's like,
well, there are it's a multifactorial because they used it on Vista rats who had
yeah,
shorter lifespans, which is helpful for researchers to realize whether a drug is toxic or not, because you, you can see by prescribing a drug for 6 months or year on Vista rats, so you can roughly equate to in humans for using it like 20 or 40 years, which is a great thing.
yeah.
But also Vista rats have normally have less cancerous tumor occurrence higher than the other rats, like albino rats or normal
Oh, I
rats,
didn't know that.
as far
Oh,
as I
interesting.
know. The dosage was a bit high, but if you equate the uh, Vista rat milligram per kilogram to human, not just one to one, it was, I guess,
Yeah, yeah, you have to
multiplying
divide
it
by
with
6.2.
point 0.081, I guess, multiplying it with would equate the human milligram per kilogram. It is still very close to uh,
Yeah.
commonly abused dose uh, among the athlete population. So athletes generally use 10 milligrams, roughly 10 milligrams or so. The
I see most using 20 actually, just like
wow,
yeah, which is not far off what they used in the study.
the blood
Although, you
the
know,
blood works I've seen as far as the managing the cholesterol, the increased ADL, increased HDL, and decreased LDL, almost like has a ceiling effect uh, after like 10 milligrams. Roughly at, I would say, after 15, I haven't seen someone who got further beneficial effects in their lipid profile after using beyond using
okay,
15 milligrams.
okay,
So
yeah. Usually, I've never really looked at it for that purpose. Yeah, that's very interesting though.
I want to mention and talk about my uh, deeply thought, actually, my methods and theories and the research that I would like to see in future on managing cholesterol. Like one of the
Hmm.
protocols I've taught for years. I'm still the I'm still updating that protocol like every month or so. The For managing cholesterol, we see that calcium channel blockers also like borderline significantly increases HDL, like lipid. They also have lipid like making your lipid profile better. They make it too. Also,
Definitely
and
gonna look into that. That's interesting.
the drug telmisartan, which is an ARB, has a partial PPAR agonist.
Yeah.
It also decreases LDL and increases HDL. Also decreases the serum free fatty acids. The combining the two has beneficial effects, and as far as I remember, there was a one paper mentioned the exactly what I said. There is a overlaying beneficial effects of both, like they have anti-inflammatory, they decrease the CRP, they both decrease it, they both increase the HDL and decrease the reactive oxygen species. So I would like to see a research that combined the two. The other protocol
That's very interesting.
I want to talk about is ezetimibe. It's quite a naive drug, side effects free almost. I thought I really thought about it for almost a year, but I realized how ezetimibe worked via bile acids, etc. Because when your body absorbs cholesterol, it uses bile acids. So I thought that what if we supplement with bile acids? So bile and cholesterol move to intestines better, so you can even decrease the cholesterol content of even gallbladder stones, and the cholesterols can move more easily to intestines and you can excrete more cholesterol. That was my theory. And I found a paper that combination of TADCA and ezetimibe, and it showed that the combination of TADCA and ezetimibe was superior to TADCA or ezetimibe alone for feces the feces, I guess it was called feces sterol.
Okay.
Well, does it stand for just hormones that have cholesterol backbone and cholesterol, etc.?
Yeah.
Yeah, it agrees it too. So I would like to see a research that combined those two protocols to see
That
whether
would be
those
very
had
interesting.
a cumulative effect, like 1 + 1 = 3.
Yeah, exactly. That's what we kind of want. But I really think the ezetimibe one could work quite well, for sure. I'd have to do more research into the calcium channel blockers, but that's also very interesting because we don't really have many ways of increasing HDL at this point. We know how to decrease LDL quite efficiently.
Well, the goal, at least that's what I think, but the goal has to keeping your HDL the same. The
Yeah,
goal was
yeah,
like managing the
well,
HDL to
yeah,
LDL
exactly.
ratio.
Yes, exactly. Yeah.
Do you have any theories or any research that you'd like to see in future, like combining the drugs? Any protocols that you'd like to see in future?
I don't have any protocols. I haven't really looked into protocols for decreasing cholesterol just due to the fact that most people, if they're on PEDs, that is, seem to benefit through just lifestyle measures. But definitely for there, because of the so many due to like all of the contraindications of statins and stuff, it would be important to come up with different protocols or alternative protocols that could benefit people and decrease mortality. But yeah, well, usually my protocols are just lifestyle based as well as using um, certain supplements such as red yeast rice extract or whatever it is, which is essentially like a statin, but and then I've also noticed with citrus bergamot, or the stuff they use in Earl Grey tea, that seems to
Yeah,
have quite a beneficial effect. Although nowhere near as good as pharmaceutical grade stuff, but still,
yeah.
I mean, it prevents you from having to hop on medication.
Well, so we know that niacin just does not reduce the mortality rate. As far as I remember, it was actually like insignificantly increase the actually insignificantly increase the mortality rate like 1% or something like that. It was ridiculous. But I would like to see a research that combined the citrus bergamot with niacin, whether they had reduced the mortality rate. Because so far, we don't know that citrus bergamot whether reduces the mortality rate or not. But we for sure know that decreasing the LDL, so far, almost all of the drugs that lower the LDL reduces the mortality rate, but increasing the HDL doesn't work for everything.
Yeah,
So
exactly.
I would like to see a research that combined the citrus bergamot with niacin, whether it to see whether it has effect or not on mortality, because of two things. One, niacin decreases the insulin sensitivity, but we have research that show that citrus bergamot increases the sensitivity. So whether maintaining the insulin sink, whether maintaining the insulin sensitivity makes the niacin or the combination work better. And the second, I can't remember the second thing, sorry. So I want to also mention the blood pressure issues we have talked about before the recording, also while recording. But there is also almost two consensus about using blood pressure medication on when someone is on cycle. Like people on the some people say that you don't need hypertensive medications when you don't have blood pressure issues on cycle, and some people take one thing to the another extreme and say that you have to use blood pressure medication like almost half of the maximal prescribed dose, or even the highest dose someone can prescribe on cycle. So if you ask my opinion, as far as it is for the most things, the truth is neither. It's somewhere between the two.
Yeah,
so
it definitely is.
Well, please go ahead.
Well, I was just going to say that, like, even if you don't have a blood pressure increase on cycle, that doesn't necessarily mean you couldn't benefit from, let's say, a compound such as an ARB, due to like what we know as the whole angiotensin 2 upregulation that is seen quite commonly on cycle, which doesn't always necessitate an increase in blood pressure. Although usually in most individuals it would, but if you're on super physiological doses of any hormone, you are more likely to have this stimulation of, or not necessarily stimulation, but upregulation of the renin-angiotensin aldosterone system.
Agreed.
And just so I think it should be taken care of. How much you need is not very clear to prevent the effect of having these, high levels of angiotensin 2 and aldosterone, but it is known that they do cause a lot of problems down the line, and trying to control them, even if you don't have an increased blood pressure, would be important, in my opinion.
Well, we have tons of research that shows that angiotensin 2, like with hyperlipidemia, just accelerate the development of atherosclerosis. If we just put the polypharmacy into equation, let's say anabolics, there are many things. There are solvents, carrier oils can increase your C-reactive protein, then that can further accelerate the development of atherosclerosis too.
Yeah, interestingly, sesame seed oil and cottonseed oil seem to be the best from what I've seen in people's blood work. It
Well,
doesn't seem to increase CRP.
well, actually, my opinion is a bit different about what majority of people think. Uh, MCT oil has I always think the extreme people like. Just a second. I always think the extremes, like there are many people who just homebrew steroids and sell it to people. They're just
Yeah.
they're just called bathtub chemists.
Yeah.
And there are also people who brew their own gear in their home. So I was thinking about uh, just making the goal should be making the final product sterile. So how can
Yes.
we obtain that? The one of the ways I thought is using MCT oil because it has capric and caprylic acid and it has antibacterial effects like cleaning some surface with vinegar, like bacteria die because of their pH value. So the same,
Yeah.
something very similar applies to MCT oil too. When I've I've read research that uh, they put MCT oil in milks. Just what do you say in English? Like I'm going to say obtain from cows.
Yes. Yes. Yeah.
And cows that has disease on their breast tissue. So milk is contaminated. They put MCT and uh, over 95% of the viruses die. So that was an eye opener for me
That's interesting.
to realize that capric
That's
and
very
caprylic
interesting.
acid is a really effective thing. And most people,
And
it's a very thin oil, so most people don't have hard time injecting it. It's very smooth.
yeah.
But uh, I tell people this like that. Because of its viscosity, your body absorbs drug faster than it normally is. If you compare to, let's say, uh, cottonseed oil or what was it? There was an olive oil product that was was it olive seed, something like I don't remember exactly. It absorbs faster than it. So your,
Okay.
let's say, testosterone deconate, which is the deconate and undeconate, is
Yeah.
probably the uh, longest ester you can prescribe legally in most countries.
Yes. Yeah.
Testosterone deconates behaves like testosterone enanthate. It half-life quite drastically decreases. If you uh, have a product like let's say testosterone enanthate brewed with MCT oil, it pretty
Yeah.
much behaves like testosterone acetate or even slightly shorter than it.
Really? That's
Yeah, yeah,
very
yeah. I've
interesting.
seen blood works that quite high testosterone values even after like injecting testosterone deconate brewed with MCT like after 5 days or so after the first shot. I've seen quite quite high
Yeah.
testosterone
I,
numbers.
that's very interesting. I wonder, but yeah, I mean, when they talk about like half-life and stuff, it also depends on how fast it's absorbed from the injection site
Yeah,
into your bloodstream. But I wonder how that works exactly, because surely it still would take that the with the decanoate ester, surely it would still take around 21 days in order to break off an ester of that size, or am I wrong on that?
Well,
Once it is absorbed
deconiate
into
is
the
still
blood.
deconiate. Just it enters the bloodstream as a deconiate. It enters the bloodstream faster, so
Yeah.
esterase and hydrolysis process can start earlier. So that's why it
Okay.
shortens the half-life. At least
That's very interesting.
so far, that's what I've figured out.
Yeah, I'm sure. Yeah, because I'd be interesting to like see studies where they compare these different oils and find out. I'm sure there actually are where they find out how quickly they can find it in your blood system once being injected into, like the glut or something. They just have to, put a sitting IV thing and just measure it as time goes on.
There is a also interesting thing I found is uh, the balancing. It's about balancing the faster absorption via injecting into the subcutaneous tissue. So you, let's say you have testosterone enanthate brewed with MCT, that it behaves like testosterone acetate. If you inject that testosterone to your subcutaneous tissue, it pretty much behaves like, again, testosterone enanthate. The absorption slows down, so it equates, just it becomes
Okay,
the
that's interesting.
same, about the same. Not
Sure,
so.
that's very interesting.
We talked about angiotensin too. So I did a video about suppressing the angiotensin too, and I talked about the term about it's a term that nobody ever talked. I called it microdosing ARBs, like subclinical doses
Oh, I saw, I saw.
when using androgens. So because decreasing the blood flow to kidneys is another issue, like having very low
Yeah.
very low hydrostatic pressure in glomerulars, and very high hydrostatic pressure is uh, as harmful as low too.
Yeah. Yeah. Like,
So what I figured out is like using like the lowest clinical dose for telmisartan is 20 milligrams. Like
mhm.
in someone's first cycle, they can use like 10 to 20 milligrams of telmisartan, and uh, watching their blood pressure, and if it doesn't change, and if keeps this it and if it's the same throughout their cycle, so they don't have to change their 10 to 20 milligrams, and they can prevent many things from like polycythemia to left ventricular hypertrophy to decreased ejection fraction to kidney damage induced by glomerular hyperfiltration to many things.
Yeah. So yeah, I definitely, that's how I also suggest it starts. You start with the lowest dose and always titrate up to effect. But it's one of the reasons it was initially thought when Viagra and Cialis or PDE5 inhibitors or whatever they're called were first introduced. They were like, oh my gosh, this is extremely renal toxic. But it's because they dilate the efferent arteriole to the glomerulus
Yeah,
so much that it drops the hydrostatic pressure and you have this massive drop in GFR initially. So, but they've actually found over time that it's actually quite beneficial.
yeah, it depends on the context. Let's say someone has baseline value GFR of 90 and they begin hyperfiltrating. They have like start having like GFR readings of 110, 115, and
Yeah.
when you prescribe them ARB, their GFR comes back to 90, or if they damaged they have if they have little damage in their kidneys, let's say it drops to 85 and 88, they freak out. Wow, it's like 30, 40 points of decrease. Actually, the baseline value was 90 and it just decreased by 5 or 10 points.
Yeah, exactly. Yeah, which is why I just suggest that everything above 60 should be considered decent, and you need repeat measures because GFR alters drastically day to day.
Agreed.
I've seen that when collecting UNDs for patients. It's if we, especially, I've seen a few patients who are like, in their last few days, they have cancer and things, and they're no longer drinking as much, and suddenly their GFR is non-existent. And I had to do daily UNDs, and it all depended on whether they ate that day, whether they didn't eat, whether they drank, whether they didn't, whether we could get a drip in. So it's always take it with a grain of salt, but as long as it's more or less consistent, you should be good, I think.
Also, I remembered very interesting thing that amlodipine, which is a calcium channel blocker,
Yeah.
was not behaving like the many other calcium channel blockers. While increasing the GFR value, it actually improved the filtration fraction instead of worsening it. So it behaves like something between like an average calcium channel blocker and ARB ACE inhibitor. It still improves the filtration fraction among the hyperfiltrating animals, but still improves the GFR instead of decreasing it.
Yeah, it's quite a good drug to use. It's just a few people can't tolerate the peripheral edema that comes with it, but it's not that problematic.
Do you see that decrease? What do you say? Whatever. Does peripheral edema become a less common thing when you prescribe it with ACE inhibitor or ARB?
The issue is nothing seems to correct this peripheral edema besides stopping the calcium channel blockers. Just because they cause the vessels essentially in your capillary network and such, all the wet vessels before, to become so porous that it's not necessarily peripheral edema, it's gravity dependent edema. So if you're standing on your feet, you're going to get a bunch of like swelling in your feet, or if your hands are down, you could get swelling, and nothing really seems to correct that. Decreasing the dose might, and that's where you could add in, an ACE inhibitor or stuff, but it's not edema in the sense that you're retaining too much water.
It sounds like almost like a band-aid solution, like, and the underlying problem
Yes,
is something
exactly.
different.
Exactly. And like after cellulitis patients, so they have this subcutaneous infection, and sometimes it becomes subcutaneous and it damages the vessels. I've seen it in a leg. It actually happened to me, and it got quite bad. And after the inflammation subsided, my vessels were still inflamed, so I could like draw in my foot because but if I raised my foot, the edema would go away. But as soon as I put my foot down, it just swelled up, and it became like a Michelin Man type situation. So I don't know how you correct that.
Does hydrochlorothiazide help a little bit for that edema?
It's I haven't seen it help, because before a patient is given amlodipine, they're already on Ridac or hydrochlorothiazide. So it's like, and they still have the problem. It does seem to be dose dependent, but some people just I've seen like a lot of people get it from very minimal doses, and that's the problem. It like has nothing to do with fluid overload, which is the annoying part.
Well, also I wanna we have like newer like diabetic newer drugs for diabetic kidney disease besides the ARBs and ACE inhibitors, which are called Sglt2 inhibitors.
Yes.
How common the prescription is in South Africa?
I've never seen it being prescribed. We would not prescribe that in public. You can get it. No one really knows about them. So just because they're so new, like we would be the last place to use it if it's a new drug. We would use it as soon as, the rest of the world has already used it for 10 years. But the cool thing about it is in the one friend I have, he does use empagliflozin, and that seems to have a diuretic effect. It's
Yeah.
quite interesting.
You
And it's
literally
like-
pee out glucose and sodium.
Yeah, yeah, exactly. So the only info I have on that is through studies. I've never seen it in a patient, not even, your liraglutide and stuff like that. We don't use that. We go metformin, glyperamide, insulin. Those are the
What is
steps we take.
glyperamide? Was it a drug that improves
it's
the insulin secretion? Was it
Yes,
DTP4?
yeah,
Something like that? A
yes,
drug?
yeah. It's a sulfonylurea. Oh, let me quickly. Sorry, I was. Glyperamide. Yeah. Where it's been such a long time since I've used these. So yeah, it's a sulfonylurea. Kind of just helps with that, secretion of insulin. The only problem with it is if you get a hypo from it, you can't correct it with glucophage. Not glucophage, you can't correct it with glucagon if you get, a hypoglycemia from it.
Well, that's interesting.
Yeah, it's
So
that's
just
why.
it almost like breaks the feedback loop from blood glucose to insulin, pancreas.
Yeah,
It sounds like that because your blood glucose levels go down and glucagon doesn't work.
Yeah,
Yeah.
it's a weird situation. I have no clue how that works. We just know, if it's a sulfonylurea that caused it, like glyperamide, you're not going to have much luck with glucagon. So it's just, IV dextrose, and that's it.
Yeah. Also, I want to talk about another protocol that I've just recently taught, and actually my dad has hyperuric acid, hyperuricemia, and the reason is half genetics and probably he actually just he was borderline obese, and nowadays he's obese, literally obese, and has high body fat, and probably that's also one of the reasons why his uric acid actually increased since like we realized it was like, I guess, 7 to 8 years ago. Also he uses diazide, a drug called classed as diazide, like diuretic among those class. It's not a hydrochlorodiazide, but structure is closely related to diazide.
Okay. That's interesting because usually those raise uric acid levels. So I'm assuming he does have gout though, because hyperuricemia and gout are a bit different. You could have hyperuricemia and not gout, but does he have gout like with the exacerbation of the joints and stuff?
No. He doesn't have any
has
physical symptoms. No, his just blood values are off the chart.
He's one of the lucky ones then. So is he on allopurinol?
No. But he went to see a cardiologist because it affects like many tissues from your joints to kidneys to vessels.
Yeah.
The crystals damage almost everything. What is the mechanism of
even
damaging?
get
I
kidney
actually
stone.
haven't looked into it. Does they just literally Is it like scratching the surface of something, like sandpapering it? Is it the method?
Like calcification of the blood vessels, you get the similar effect with uric acid, and that's why you get kidney stones if you have high uric acid levels. But there are different type of kidney stones. Like from the typical ones, there are different types of kidney stones, and this one's composed of uric acid mostly, or I can't remember the chemical structure, but yeah, essentially they just deposit in spaces and cause problems that way. They have a predilection for joints for some reason. I'm sure there's an explanation, but it gets quite interesting because they call them gouty tophi. So like on your tendon, on your, your tricep tendon or something, you get like a bump. And then sometimes in that case, it explodes and this cheesy stuff comes out and it's just uric acid. But that's
Well,
like in serious gout.
yeah, I was talking about my dad's hypertension medication. It's actually combination of 3 medications, and I'm just going to look at what are the active ingredients in it. It was like amlodipine and an ACE inhibitor and diazide like diuretic.
Yeah, that sounds right. That's pretty much what most people are on these days.
Yeah, I found it. It is like perindoprolil, indapamide, and amlodipine. Have you heard about?
I I I have. We don't use that though. But yeah, we don't even use the ACE inhibitor that you mentioned. We use Allopurinol or lisinopril. But yeah, that's very interesting.
Well, I was telling him not to decrease or halve his dose because he has borderline blood pressure of 120/80. Sometimes it's 115/75, something like that. He thinks about lowering his blood pressure medication, and I told him that not to lower without his doctor's approval, because he
Yeah.
just he doesn't change one factor. It changes the three things. He lowers the dose of
Yeah.
the 3 drugs. So instead, I actually told him to keep his diazide like diuretic and amlodipine dose the same. Instead of taking 1 pill, just taking 2 pills. Just one of them is combination of amlodipine and diazide like diuretic. And instead of having an ACE inhibitor, I told him that just he can use a ARB that lowers uric acid. I forgot the name of the drug. I remember the active active metabolite of it. It was losartan. Yeah, I remembered it. Losartan.
I haven't heard about it with uric acid, but that's interesting. But yeah, obviously check with the doc first, because I'm sure. Yeah, but it is interesting that he is using a thiazide-like diuretic, because we tend to remove those if they have hyperuricemia, because it does make your uric acid levels worse.
Yeah, he was borderline high, and now he's off the chart.
Oh, okay. Well, you should definitely get that checked out then, because obviously, as we just discussed, it's not great to have it running too high. And
yeah,
a lot of bodybuilders have a lot of high uric acid levels.
Yeah, so my protocol was this, actually. From the research I've read, there are 2 drugs that down regulate the production. Excuse me, upregulate the excretion of uric acids. And those two are just losartan and telmisartan. But in clinical practice among the ARBs, just losartan decreases it because the excretion route is the excretion route of telmisartan is 99% feces, so it doesn't affect the uric acid. So, but losartan does. So, I would like to see a research that combined a telmisartan and Sglt2 inhibitor to see whether combination of Sglt2 inhibitor and telmisartan is superior in terms of uric acid reduction, because Sglt2 inhibitors also decrease the uric acid too, as you said.
Yeah. Yeah, that would be interesting also. I wonder the mechanism through which it happens, because usually the drug allopurinol is like a xanthine oxidase inhibitor, and that's how it reduces your uric acid through secreting it in your urine. And I wonder if the combination of those two would be better than using allopurinol. Because if we think about it, like most people with high uric acid levels have metabolic syndrome. So they already have the high blood pressure, the high
Yeah.
lipids. So perhaps it would be more beneficial to, and poor insulin sensitivity, to combine two agents with, and that would take over the role of adding something like allopurinol. So it'd be interesting to know.
What are the side effects of allopurinol? Which this I haven't even researched whether the side effects or harmful
Allopurinol,
effects of allopurinol.
there is quite a big one, and I've completely forgot it. Excuse me, it's been a while. Um, so I think it gives you like a transient hepatitis, but let me just check first. Um, they just I'm quite sure, because it is metabolized by the liver. It's something to do with the liver, but I can't remember. So yeah, there's not a. It's quite a
Does it
potent
prevent
drug.
bile acid flow? Is it how uh, does
I'm
hepatitis?
I'm not sure. It might be more of a drug-induced hepatitis through
Uh-huh.
its pathway, because it seems to work with this one enzyme. But I'd have to check that and get back to you on that, because I'm not sure. Because yeah, I'm really not sure. I can't remember. It's been a while since I've used a drug like that.
Also, I remember that in the beginning of the recording, I said that oral steroids decrease the intrahepatic lipase, but I remember that actually it increases. That's how it decreases the HDL count. It's the opposite of
Oh, I
I've said.
see. I see. Yeah, yeah. That would make more sense. I just heard lipase, and I assumed, yeah. But that's very interesting. Yeah, but it's interesting because all of these drugs have different mechanisms through which they affect different pathways, and by combining them, perhaps we could get rid of other unnecessary drugs. Yeah, very interesting area of research.
Okay, so we were talking about SGLT2 inhibitors. So, uh, at least in theory, would it be beneficial for bodybuilders who have higher body fat, higher muscle mass, and also has, so let me recap. Would prescription of SGLT2 inhibitors be superior to allopurinol for slight reduction in uric acid amongst the individuals who already have fatty liver disease? Let's say a bodybuilder who abused the hell out of insulin, and developed
Yeah,
fatty liver disease.
yeah. I mean, I don't think you can. I think like allopurinol is quite hepatotoxic, so I think
Hmm.
SGLT2 inhibitors would, in that case specifically, because we don't really have any other mechanism other than diet through which you could try decrease that. And I honestly I do think SGLT2 inhibitors are going to show quite favorable research in the future. They're still new, but I'm fairly confident they're going to be quite useful, especially for bodybuilders, because bodybuilders already have like obese phenotypes. Although it's muscle, it's like they are obese because of all this muscle they have.
Yeah.
So I think they could benefit from it.
Yeah, also your body almost doesn't care whether, mostly, at least mostly, doesn't care whether the
Yeah,
extra body weight came from muscle
yeah,
or
exactly.
fat. That to a point, I would say like it is 80% the same, and there is also, of course, 20% difference of uh, benefits of increased insulin sensitivity and decreased reactive oxygen
Yeah,
species,
exactly.
etc. But I would say it is 80% the same for your blood pressure. Or
Yeah, I mean, exactly. You're you're exactly right with that, especially if they were abusing insulin.
so we also I want to talk about the myocardial benefits of SGLT2 inhibitors. It seems like it decreases the infarction size after the heart attacks, and I really thought about it. It seems like it helps ATP production after heart attack via ketones. It seems
Like,
like it is the
okay.
one of the ways that SGLT2 inhibitors decrease the infarction size. Also, there are like decreased CRP, decreased free radicals, etc. But I really thought about it because there is another drug for ischemia purposes used for, also abused by famous tennis player, female tennis player Mario Sharapova. She came positive for it, like I guess it was 5 years ago or 6 years ago or so.
Yes, I remember.
Meldonium, it is called. It actually does the opposite. It decreases uh, it depletes your L-carnitine, so you cannot generate ATP whatsoever from uh, fats, fatty acids. So your body uses more glucose. So it makes sense for
Yeah,
it decreases the infarction size, and it makes sense because your body's preference is always glucose for ATP production. So it, let's say, makes injured cells live easier because they can generate ATP much easier. With that
yeah.
analogy, it makes sense. But I would like to see a research that combined SGLT2 inhibitors and meldonium to see whether they have uh, synergistic effects.
That would be interesting. I remember the whole Sharapova thing. That
Yeah.
I'd be interested to see how that plays out. I honestly could not tell you if it would be how much of a
Yeah,
benefit it would be, but
more research is needed. It's not always it's always not enough. Scientists always want to see more research, and they should want also.
yeah, I mean that's the only way we can make new
Yeah.
recommendations. That I mean, it doesn't. I also heard that. Well, I mean, through another mechanism, surely it would decrease infarction size by decreasing the demand by the myocardial tissue.
What, excuse me.
Because
Could you repeat it again?
I'd just be wondering if it would decrease the size of the infarction via um, decreasing myocardial demand. because
Uh-huh.
it does seem to reduce the actual cell size of the myocytes. If I'm not incorrect, I mean, if I'm not mistaken, but that's SGLT2 inhibitors, and I've heard that it also decreases the demand by the actual cells themselves for energy requirements. But I don't know. I've heard that it can be quite beneficial in growth hormone abuse due to growth hormone causing this almost edema of the myocytes, and SGLT2 inhibitors decrease this. So
Yeah, yeah.
I don't know. It's
It's
just like,
again multifactorial. It is like there is increased increased angiotensin 2 levels because of growth hormone. Also, there is hyperinsulinemia because of growth hormone. Also,
yeah,
we know that higher angiotensin 2 expression, AT1, higher AT1 stimulation results in higher sodium glucose transport expression too. So it's multifactorial always.
yeah, exactly. It's always difficult to know what the actual cause is, but I suppose there are many.
Does I was also thinking about the bodybuilders who already uses ARBs and they just decided for whatever reason they decided to abuse growth hormone like dosages over, let's say, 6 IUs. They, let's say, some freaks use over 10 IU. So when they use, it's inevitable to have fluid retention.
Yeah.
It will be there. So sodium and fluid retention will be there. Would it be a great, better idea to first using ARBs and then introducing the SGLT2 inhibitors because, as I've said, higher AT1 receptor stimulation further increases the sodium glucose transport. Uh,
Well,
I forgot the word. I'm
yeah.
gonna. What it be?
Uh,
I guess you got
I
what I
know
mean.
what you're
I
saying.
guess.
Yeah,
Yeah.
no, I know what you mean. Yeah, that's so interesting. But I think they could benefit from the use of both, because as you mentioned, most of the fluid retention seems to be centered around an increase in sodium and glucose, and obviously that's the mechanism by which these
Mm-hmm.
SGLT2 inhibitors work, and they get rid of that. And that in itself is quite, well, it has a damaging effect to the body in a different way, but at the same time, you have the, as you mentioned, the angiotensin system being messed around with via growth hormone. So I think you'd have to use low doses of both if
Maybe
you were to cover yourself.
maybe they can use even a lower SGLT2 inhibitor via using using an ARB like telmisartan,
Yeah,
which lowers serum free fatty acid levels. So that's how growth hormone. Also, that's how growth hormone makes you insulin resistant. So for insulin sensitivity purposes, maybe they can use even a lower dose of SGLT2 inhibitors, like even
yeah,
microdosing, like maybe one
yeah,
fourth of the lowest prescribed dose or something like that.
yeah. I mean, theoretically,
Yeah.
ARBs decrease aldosterone, which would inhibit sodium reabsorption, via which aldosterone works on that potassium sodium transporter in the nephron. So, I mean, but the only issue is the glucose. So, yeah, and you don't get that from ARBs, so you'd still have to include something, some sort of diabetic medication, especially on growth hormone. I mean,
Maybe except
you
the
get,
telmisartan, maybe that might be the one that slightly manages the blood glucose.
I did look at the research and it doesn't seem so
It's not very
promising, but I'm
consistent
not saying,
actually. Some studies show that there's not statistically significant difference between a losartan and telmisartan. So it's not very
but I
consistent.
mean, supposedly, like if they were using a low dose of growth hormone, it might then, in that case, telmisartan or something might be able to control it to that extent.
I
But
speculate that the major, at least not major, I would say at least 40% of the insulin sensitization comes from the reduction of the superoxides, etc. The just decreased levels of reactive oxygen species and increased glutathione. I would say that. That's my speculation. I don't know if it's true or not, because we know that reactive oxygen species can decrease the insulin sensitivity. Makes the GLUT4 translocation inefficient.
Yeah. Well, from obviously this is just from a basic perspective of how GH works. I would have thought it was the high resting blood glucose levels, since growth hormones itself is a hyperglycemic agent. But I mean, what you're saying with the whole oxidant in this case effects, they're so systemic in their ability to cause damage that I think, I mean, that could lead us to discuss something like using taurine or, a potent antioxidant. But I don't know of many studies that looked at long-term effects of taurine in actual humans. I mean, there's no doubt that it's potent in causing, or like, as well as N-acetylcysteine, there's no doubt that they are antioxidants, but whether they change morbidity or mortality, I don't know.
Yeah, N-acetylcysteine also is an interesting thing, because you see some research that show that they decrease the contrast-induced nephropathy. They decrease the toxicity of contrast fluids. But at the same time, you see some research that for some medications, NAC does not change their toxicity that much.
Yeah.
So
I mean,
you can modulate that to a point, I guess.
Yeah, I honestly don't know. I just prefer taking antioxidants just in case, but it could be a waste of money. But as long as they're not causing harm, and there's always that, you always take into consideration that risk to benefit ratio. That's kind of what I base things off of. But yeah, I don't know if you do the similar thing, but yeah.
Well, I'm not actually a fan of antioxidants, except someone abuses androgens, insulin, growth hormone, many things. I'm not a fan of it because when you combine like resistant training with high antioxidants, they can interfere with adaptations, of course. Also, like if somebody eats like whole food instead of what do you call it? Super sugary things.
Yeah.
Whatever it is called. Processed foods, yes. Instead of processed foods, they almost cover their like daily vitamin and mineral needs almost like one to one. But also there are things that supplementing won't harm, like maybe like low doses of vitamin C, like maybe 250 to 500 milligrams a day of vitamin C is that dose of vitamin C's interference with adaptations is negligible. I think that if it's less than 1 gram.
Yeah. I think I take 2 grams a day, just due to, I found it helped a bit with tendon health from me personally, but yeah.
Yeah, I take that off. I used to take that after my regenerative injections for my tendons. For example, prolotherapy. Have you ever heard about it? Prolotherapy.
Bromotherapy.
Prolo.
Prolo.
Yeah.
I
It comes
don't
from
know.
proliferative therapy.
Okay.
Therapy. Yeah, it's nowadays the solution they use is like 75% of, I would say, actually like 75 to 90% of the doctors just use highly concentrated dextrose, like 15% to starting from 12.5% to up to 25% of dextrose injected to entheses, the connection part of tendons and bones. They just inject it
Yeah.
and create an inflammatory response, and your body lays down collagen, etc. It's like it's like a resistance training, like damaging
It
your
seems to be,
tissues to a point where your body can recover.
yeah. Yeah, that sounds very interesting. Exactly the same as weight training, I suppose.
Yeah, I used it with vitamin C with actually hydrolyzed collagen like type 1 and type 3, and I found that uh, on the contrary of some biology teachers taught us when we were young, that every protein is about the same, you just ingest it and your protein goes to tissues, and uh, your your organelles in cell express proteins, and if it becomes it becomes a collagen and tendon, it becomes a collagen on your skin, it becomes actin and myosin protein on your muscle,
Yeah.
etc. That's
Yeah.
what they taught us, but it seems like the collagen excuse me, amino acids in collagen, like what what were they called, like polypeptides, I guess.
Yeah. Yeah.
Two or
Polypeptide chain.
two or three amino acids connected with them. Uh, they seem like it seems like they get ingested to bloodstream without breaking down fully. So
Mhm.
they seem like effect, and in my personal experience, it works actually. It decreased my tendon pain, like I would say 20 to 25%.
Very interesting. Uh, I obviously haven't experimented with collagen and stuff because, but yeah, I'm curious. I'm interested by you saying that it helped quite a bit.
Well, maybe because I'm speculating that also I might be a person. I'm hypermobile. I have a hypermobility. That's the primary reason why and also I still have many orthopedic problems. Uh,
Yeah.
but, but also I highly speculate that I might be like borderline hypermobile EDS, because Ehlers-Danlos syndrome in Ehlers-Danlos spectrum, like hypermobile EDS, to this date we don't have a gene that is associated with it. So I'm speculating that I might be a person that has borderline hypermobile EDS.
Okay.
Also, there are some cases, and a few doctors I've found that they think that there is a connection between what like low vitamin C levels and EDS, because on some cases they find that they cannot boost their serum vitamin C levels, whatever they do with, if even when they use oral 3 to 4 grams of vitamin C.
Okay.
It's some
And when
interesting.
did you find out about your EDS? I assume that's short for with Ehlers-Danlos syndrome.
Well, that's a speculation because I have like multiple injuries, some of them caused by antibiotics like ciprofloxacin, I guess.
Oh yeah, yeah.
I got flux, as many people complain. Like I developed
Yeah.
tendonitis, and I still have like some snapping on my tendon, also like sandpaper feeling. It got better over the course of years, but when I was using, I was feeling like there was really my elbows were inflamed. I was hearing my joint as if my joints were not lubricating, and you know the sound when you like
Yeah.
wipe your windshield, your
We call it crepitus in
yeah,
medicine, joint crepitus. You actually like feel it.
yeah. Also my knees, my hips, my sacroiliac. Like thank God my sacroiliac joint like got fixed by prolotherapy. Like I would say over 90%, it's gone.
Really?
Literally. Yeah, it was like I I know that I had many like sleepless nights that I had to like have a fetus pose in order to not have pain. So it's a
Yeah.
really big improvement. So, we were talking. The last thing I want to address is androgens also.
Yeah.
The, as as we know, the androgens like they cover the over like 80% of the PED used around the world. I would say that's the majority.
Yeah. Pretty much. Uh, well, I mean, maybe not now with the invention of TikTok and the SARMs oils and stuff,
Yes, 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 yes.
but yeah, they're used to at least.
Yeah, also there's I want to address that how silly these SARMs is. They call it SARMs, but technically, it, in order to behave like a SARM, it has the modulate receptors, but it does not. We know that because selective estrogen receptors have some agonistic and antagonistic properties on different tissues, but SARMs do not
Yeah.
have those yet. They're just uh, weak selective androgen receptor
Yeah,
activators that
exactly.
lose selectivity with higher doses.
Yeah, they're just partial agonists. That's all they are. They have no antagonistic ability. And if you look at it at a dose, when they start comparing doses similar to testosterone, they lose their selectivity. And it's like it's the same. I mean, it's not tech. I mean, some people call it a some people don't. But with trestolone or ment, that is considered like to be selective. But when you use a dose similar to testosterone, it becomes 5 more times more prolific on the prostate, which is exactly the reason it was developed, was so that it would spare the prostate. But yeah, exactly. They're just partial agonists. They're not modulators in any sense.
Well, I also have a theory about the managing of lipid profile by uh, managing the androgens to estrogen ratio. We know that androgens can stop growth signaling, at least decrease the growth stimulus, because we
Mhm.
historically used testosterone and methyl testosterone in breast cancer
Yeah.
patients. So I was speculating that whether is it possible to have a better lipid profile by just combining the drostanolone, which is masteron, also known
Yeah.
as masteron, with estrogen, as far as someone can tolerate. Because we actually don't have any data about masteron that shows that it has directly antagonistic properties different than any other DHT derivative androgen. But anecdotally, we see that it has something like, I would say, like 10 to 20% different than, let's say, metanolone, primobolan, in terms of estrogen. People get super, like I would say, pseudo low estrogens because of masteron. Because I would like to see a research that shows modulating like lipid profile with high dose estrogen combined with drostanolone, because maybe I know it doesn't have direct antagonistic effects, but maybe it has higher antagonistic properties on some tissues and lower on the others. So maybe your for your cardiovascular system, you might get, who knows, maybe a better profile.
True. Yeah. Exactly. I think the only issue with that protocol is they haven't really demonstrated that drostanolone can maintain like male sexual behavior in studies. I don't think, which would make it a slight problem because it would inhibit your testosterone levels, which could be a good thing.
But I would argue that the estrogen holds a place as a like you know, like a foundation of building. If you like literally have no estrogen, your sex drive goes.
They found that, like, especially in the rats and studies, those Wistra rats, that in most animals, estrogen is the most important hormone for males if they want to have a libido and sexual interest. Whereas with humans, they found there was an interplay of having a balanced androgenic to estrogenic ratio. And if it's skew, they realized that, you won't have a libido or something, which is why a crashed estrogen will cause that problems, but so will too high estrogen. And if you have no DHT and estrogen, it's complicated, especially in humans.
Also, I know. I talked about many protocols or theories, but we know that you just can only convert testosterone to estrogen or dihydrotestosterone to a degree, because you have aromatase and 5-alpha reductase enzymes. So when you increase the dose, after a point, the percentage that gets converted decreases. Like after like 600 or 800 milligrams, the percentage converted to estradiol goes, I guess it was from 0.5 to 0.3%, I guess, if I remember correctly. The percentage drastically goes down. So I was speculating that whether it is possible to see no estrogenic effects via just injecting like testosterone of 5,000 or 6,000 milligrams per week in rats. I would like to see that, whether the skewed testosterone to estrogen ratio just neutralize the high estrogen effect, like breast growth, etc.
Discuss that.
Yeah.
I saw that on a forum, but no one really knows. But I mean, it's an interesting theory, but I don't know if anyone wants to give
in
that
practice, they would probably have hard time breathing because of the fluid retention after like 1.5 gram.
I mean, it's no joke when people just start TRT and they inject 100 for the first time. They get the fluid retention, their mood swings. I've seen that a lot. And I can't imagine going.
Yeah, it depends on how you metabolize, how heavy you are, how big you are. The roughly 1 milligram per kilogram is like almost the rule of thumb for TRT, also for like
Yes, yeah,
female to male transitions, like uh, female to male transsexual individuals, just they use like 50 milligrams a week and boom, they just gain muscle, they grow a mustache, and it works because they weigh like 45 kilograms.
yeah. I know.
Yeah.
Yeah, always it's interesting. Like I always said, yeah.
So, what what should like bodybuilders, etc., what should they do to prevent uh, like heart growth, or skewing their profiles, or skewing their lipid profiles, or uh, damaging their kidneys? What they can do to prevent those, mainly and in details. And later, I would like to hear your ideas on that.
Yeah, I mean, it's it's like comes. It's a whole bunch of different stuff, especially with the heart enlargement. There are so many different pathways via which steroids could possibly enlarge it, like through increase of blood pressure, but not only the increase of blood pressure, how it's increasing the blood pressure with the stimulation of the RAS system. That also increases the heart size, but not only that, there are actually androgen receptors within the heart that hypertrophy. So it's like
Yeah,
I
it's
don't,
another debate that actually, till I guess till like 3 to 4 years ago, there was no known functioning androgen receptor on heart, and they show.
yeah,
I've read research, but they showed different results for like simulation of heart with dihydrotestosterone and
yes,
normal testosterone. Dihydrotestosterone had more, I would say, if I remember correctly, it had more cytotoxic and more
yeah, it
hypertrophic
was,
effect. Yeah,
yeah, it increased, both caused hypertrophy, but I think it was the DHT that increased atrial natriuretic peptide
hmm,
levels, which is like usually raised in patients who have heart failure.
yeah.
That's like a peptide you can use. It's not very specific, or but yeah, it was interesting to note that DHT itself was a lot more potent than testosterone in stimulating the androgen receptor.
So we said controlling the blood pressure is the rule one. Also, for the controlling of the for the controlling purposes of the blood pressure, the body weight also counts too. Maybe like avoiding the heavy use of like progesterone derivative drugs like nandrolone, and
Yeah,
conservative use of testosterone might be a better choice for blood pressure.
yeah, exactly. I know for a fact that a lot, okay, I can't say it's a fact, but nandrolone seems to be spike blood pressures through the roof. I've seen people go from normal blood pressure to 170 over who knows, but nandrolone seems to be quite potent, more so than tren, although tren isn't that harmless either. But nandrolone, for some reason, seems to spike heart rates and blood pressures.
Yeah, for heart rate, I would say the opposite because trans beta agonistic properties.
Um, it's
Just
I
for heart rate.
for heart. Sorry, what's the question?
Well, in my experience, from what I've seen and observed, tren raises the heart rate more than nandrolone.
Yeah, so yeah, I may have said nandrolone. I just know nandrolone does increase it, but the
Mhm.
blood pressure seems to be worse with nandrolone, but it could be bad with tren, but I haven't seen that as often. But yeah, with the tren, your heart rate goes to like a resting of about 80 to 90 when it was 60 initially.
Yeah, what do you think about the drugs that have not even historically approved for human use. Should bodybuilders avoid using those compounds?
If they haven't historically been used for humans. Yeah, I mean, if you want to do it the safe way and like have science behind you, I
Uh-huh.
suppose that's the best thing you can do, because then you can base all of your recommendations off research. But if it's only been done in animals, I mean, some SARMs have been done in humans, but that's the problem with SARMs. They're only really animal studies. So it's like, how do you base your recommendations? You're basing them off a forum, and the guy could be lying. It's like, you
So what
don't
do you
know
think
that
about
person.
YK11, which is so-called SARM, and actually an
Yeah,
androgen?
I mean,
It
I've
doesn't
I've
even
seen it.
have an animal study at all.
I honestly, I've I don't know anyone that's experimented with YK11, but that's because there's only one source for it in South Africa. But I mean, yeah, I wouldn't. Personally, I would not touch anything that doesn't have research behind it. And there's so many drugs that do have a lot of clinical research. You just have to look for them.
What we have just said is actually contrary to people's experience in terms of avoiding historically approved compounds, which is because of this. Tren in high doses is kidney toxic. How do we know? It's anecdotal experience, tons of experience.
Yeah,
But with boldenone, it's it seems like it is kidney toxic. It drastically increases the reactive oxygen species, etc. It's kidney toxic in many ways. One of the ways is probably, I speculate that it's from a higher hematocrit level, which decreases the plasma portion of the blood. So your kidneys is less hydrated. I would say they have to filtrate more nitrogen, etc. There are many reasons behind it, but boldenone seems like it doesn't have the same kidney toxicity per milligram. I would say boldenone has lower kidney toxicity per milligram when you compare it to trembolone.
okay. I don't know about that, like
Yeah,
comparing them, but I do know about, like, I've seen enough cases for myself to be certain that tren is quite renal toxic. Um, in terms of boldenone, there's just that one study done with the ultrasound, and they saw that renal cortices.
yeah, in
So
humans,
like,
but in animals we have more extensive research in terms
yeah,
of boldenone's
usually
effects on
with most
kidneys.
drugs. Yeah, yeah. There was just the one in humans, I think, and then the rest were done in like rabbits, I think.
The also there is a people just science-based, let's say, bodybuilder coaches, or people who call them coach of the coaches, uh, uh, like to use trembolone as it blocks the glucocorticoid signaling, downregulates it. So they they have less muscle breakdown, and they synergistically, like combining low dose like 50 milligrams of trembolone with like a gram of gear in total, like makes 1 plus 1 equals 1 plus 1 equals 3 effect. Like I was
Yeah,
speculating that also 19 nor testosterone, like nandrolone, deca, also has the uh, that glucocorticoid blocking effect, but to a lower extent. But we know that for nandrolone, no one runs nandrolone almost lower than 200 milligrams. In nowadays, like bare minimum is 300.
yeah.
And it
I've
might
never
be
even seen
actually
300.
actually the effect might be exactly the same with like 50 milligram of trembolone compared with like 300 milligrams, excuse me, 50 milligrams of trembolone compared with 300 milligrams of nandrolone. So their glucocorticoid blocking effect might be roughly the same. I speculate that. But if it's not, I would actually, if I were using for glucocorticoid blocking properties, I would just add just 5 milligrams of oxandrolone just for glucocorticoid
Yes,
blocking properties, and
that that
that would
that's what I was
balance.
about to say. Like, I was gonna say, like, a lot of people don't realize that oxandrolone is also, it blocks the glucocorticoid receptors, and that was proven in 2 different studies. But so was testosterone. A few what you call it do. I mean, and androgens do, but I think um trend seems to have maybe possibly a stronger effect. I don't know. I haven't really quantified
Yeah,
it,
has a
but
stronger effect compared to milligram per milligram. Yeah.
yeah, I would assume so.
But I was wondering whether I was uh, thinking about the safety of trembolone. Is it safe?
Mm.
I was thinking about whether is it safe to use nandrolone plus like 5 milligrams of oxandrolone to block glucocorticoid signaling equal to trembolone while having a lower side effect profile, lower health impact on even HDL to brain health to cardiovascular, to renal health. So, what are your
Yeah.
opinions on it? I would like to
Well,
hear those.
opinions, I dislike trend with a passion, so I would always opt for the option without trend. But um, yeah, even in that scenario, if I was given 2 choices, I would still go for the nandrolone option, because even though I'm a nandrolone plus oxandrolone option, because although it's just because those compounds have, I mean, nandrolone itself isn't necessarily the safest either, but
Yeah,
oxandrolone has quite a good safety profile and has benefits, well, benefits other than just being anabolic. But um, yeah, I'd always go for the option without trend, just
yeah.
because of
Also,
trend.
someone doesn't need to abuse high doses of oxandrolone. For burn patient, they use like 20, 25, 15 to 25
Yeah,
milligrams of oxandrolone a day for almost whole body burn patients. So you don't even need that. Like 5 milligrams goes a long way.
yeah, exactly. 5 milligrams, yeah. So just, I mean, 20 milligrams in most people doesn't give them insane gains, but it gives them, decent amount for the side effects you get, which
Yeah,
are virtually
nowadays
none.
people just want to feel like side effects, like the
Yeah, that
aggression,
like
etc. They know that via that they know that the
it's working.
drug they use is real.
Yeah, exactly. Like that. If you ask someone, how do you know it's working? And it's like, well, I got a crazy headache and my pumps are insane. And then like you realize the pumps are insane because I have all this water retention. And it's
Yeah,
like, do you really want that? Because that's gonna go away after you stop the compound.
yeah, that's probably why most people uh, think that masteron, primobolan, oxandrolone is a weak
Yeah,
drug. Well, they say that.
exactly.
Well, I don't feel anything. Let me tell those
Yeah.
people, you don't naturally feel your muscles grow normally at all. That you don't feel it,
Yeah.
and you shouldn't.
it's it's funny, yeah, because I'd be curious for people to like show, okay, this was me doing a test and debol cycle, and then take a photo a few months after the cycle, and then compare that to them having done a test and master on cycle, and see where they are a few months after that. And it's like, is there much difference? And did you really need that spike in blood pressure from debol?
Yeah.
No, well,
Well, here is the here the here comes the fun part of the podcast.
yeah.
What would you do if you had, let's say, you had a heart attack in your 30s and you have all the options to use uh, pharmacologic drugs that approved for human use? Drugs would what drugs would you use? in that case, in that scenario?
So wait, so I had a animal with a defect, a heart defect.
Excuse me? Animal.
Sorry, was it an animal or a human or a patient or?
I'm. I said if you were, if let's say
Okay,
you had a heart attack in your 30s in future.
okay. And what anabolic would I
No,
use?
it might be anabolic to estrogen to blood pressure medication to beta blocker, calcium channel blocker. I'm asking for full list to common to uncommon drugs that you will prescribe yourself legally, like approved for human use.
Okay. Well, I mean, if I had a heart defect and I didn't need an androgen, I would stick away from androgens. It would also depend on the heart defect, like what kind of defect it was. Um, if it was like a rapid heart rate, I'd have to go for a beta blocker. But if I'm active in the gym, I wouldn't want to go for a non-selective beta blocker, so I'd have to go for a selective one. If it was due to high blood pressure, I'd need to control that high blood pressure because that can exacerbate heart defects even more. Um, Cholesterol, I would, in the case of having a heart defect, in that situation, I might consider going on a statin. Um,
Would
but
you also
yeah,
combine statin with a coenzyme Q10 just
yeah,
because it depletes?
that's a staple. I mean, it costs so much here in South Africa, but if I could use it, I would use it all the time. Just
Actually,
due
I
to
found a product in my country that has four products. A fish oil product that contains vitamin K, very low dose of vitamin D, high dose, uh, I would say average to slightly higher than average dose of vitamin K, and ubiquinol.
yeah, so it's got that complete cardio
Yeah, yeah,
protection.
yeah. So it's a super compound, and if that was like in the every pharmacy around the world, I would advise like steroid user to take like 3 to 4 caps of it every day when they're on cycle,
Yeah,
and 1 to 2 when they're off for the rest of their life.
I mean, yeah, I wish we had those supplements. Because I mean, we have to buy everything separately, and everything is super expensive. The supplement market here is a big place to make money because everything's so expensive. But yeah, vitamin K,
Is it a monopoly
K2
market like are there many
yeah, there, I mean, there are tons of different supplement companies.
haha.
We have way too many. That's an issue. And then they all of their supplements have the same price and the same milligram per price. So it's like I don't. It doesn't matter which company you use, but they'd never combine them. If they do combine them, they combine them at arbitrary doses. So it's I mean, I have to buy them separately. I usually order them online from abroad because that's the only way you're going to get a good dose.
Well, if I were, mind if I talk about
Yeah,
my
yeah, I'm
protocol
curious.
about if I had heart attack and what would I do if I had a heart attack? Well, it's quite uncommon actually. I would probably use cardivolol, which they prescribe for beta
Yeah,
blocker. They prescribe for people who had heart failure, people who had high
yeah,
heart failure or
it's
heart attack.
first step.
Yeah, it's drastically decreases the mortality rate compared to non-users. Also, statin. I wasn't aware of till 1 year ago. Statin with megadosing ubiquinol, like 200 to 400 micrograms of ubiquinol. I'm not sure whether it was in micrograms or milligrams, whatever.
I think it's milligrams, but I could be wrong.
Yeah,
So yeah.
I would add actually after the heart attack immediately add meldonium.
Mel,
Meldonium.
oh, meldonium, like Sharapova.
Yeah, Sharapova. The drug Sharapova got caught. Yeah, I would add meldonium and combine it with niacin. And I thought about it long ago because niacin, like, it makes fat cells to release free fatty acid to bloodstream even harder. So
Yeah,
I was thinking about a synergistic effect of meldonium forcing cells to use glucose and niacin making less free fatty acids to bloodstream. So even forcing them to use more glucose, prefer more. And
yeah.
actually, I found a uh, application for a patent application. Is it correct? Did I say? A combination
Yeah.
of niacin and meldonium. And rats show that they drastically decrease the infarction size on their heart in ischemia reperfusion study.
Interesting.
Yeah. Also, one of the things I would prescribe myself if I were a doctor legally, I would say paroxetine. And you know what it is? It's an SSRI. It
Yeah.
has it is the only GRK2 inhibitor. It is the only drug that approved for human use that has a GRK2 inhibitor inhibition effect. So we know that pathologically remodeled heart beta 2 to beta 1 receptor ratio gets skewed literally. Your heart becomes less sensitive to beta 1, as if I remember correctly. There are many research that show that after heart infarction your paroxetine improves the ejection fraction, decreases the heart size, and I would probably personally use that. And the also a very interesting thing I would use, if only it were legal, was non-hematopoietic erythropoietin derivative.
Okay. I've never come across that, but
Well, erythropoietin has many properties besides just erythropoiesis, hematopoietic
yeah.
thing. They, there are many research that show that in ischemia reperfusion studies prevents the kidney to heart to brain. It has many things, and even the things I would say 80 to 90% of what I've said also applies probably for the brain, like having a stroke, etc.
Yeah, no, it would be identical.
Yeah.
You need to reduce the penumbra.
So I'm. Was there something that I was thinking about, like protein unfolding as a disease? We know that with trembolone and 19 testosterone, with use of those, the how protein aggregates cumulatively increase in the brain is protein misfolding. A natural chaperoning, and your body has some defense mechanisms to cope with it. But if there are many, like protein aggregates, if increases misfolded protein, like they create aggregates, and the if content increases, your cells eventually they program themselves to die. That's how brain cells get permanent damage. That's how Parkinson disease to what was the name of the disease that people just start to forget things?
Alzheimer's?
Yeah, Alzheimer's. Yes, thank you. And Alzheimer's disease. And I was
Yeah.
thinking about using a TADCA, a bile acid, not naturally occurring bile acid, but bile acid derivative, let's say. TATCA have like chaperoning effect, like correcting the protein misfolding. So it seems like it slows down the creation of protein aggregates, protein misfolding. So protein misfolding is I would say, a new thing that we just learn newer things every day. So we
Yeah.
know, I would say it's a valuable tool for brain health. I would easily say that it has no side effects besides the positive effects, just positive effects. For heart, I don't know, maybe ischemia hyperfusion some studies show that it has positive effects, but I speculate that that's not because of the protein, unfolded proteins, at least mainly, just because it makes harder to express proteins healthier, maybe like decreasing the endoplasmic reticulum stress so that you can express more natively correctly folded proteins. But that's speculation. We have little to no data about it. That would be my protocol. So what's your ideas about my protocol in general? Can it be a
I
valuable
mean,
tool in future?
I mean, it could be, but the one of the things you want to do with heart attacks and strokes is reduce the reperfusion rate, because although it's important, once the cells die, they release cytotoxic agents, and if you cause this reperfusion too quickly, those cytotoxic agents go through the it's called the penumbra, but that's essentially like a zone that I'm struggling to explain it, but essentially, if you reperfuse too quickly, you cause these cytotoxic agents that came from the cells that died, and they affect the surrounding cells. So what you're trying to do is contain that reperfusion area. You don't want to reperfuse, I mean, you want to contain that area. You don't want to reperfuse too quickly, just in case it could, cause more drastic effects to other affected
Yeah, it seems
areas.
like Maldonio's effect, one of the working mechanism is what you said. It decreases the reactive oxygen species, and it almost like trains heart to work under like even a heart attack. Like even like it's how can I say, an adaptation occurs. I would say that.
Yeah. Well, I mean, it's like one of the reasons sometimes they use cold, what they stick, if you've had a stroke, they do that hypothermic therapy where they lower your core body temperature, so that causes vascular constriction, so that the rest of the body or
Mhm.
the surrounding part of the affected area in the brain or is not affected by this reperfusion.
Wow, I didn't know that. So
I,
it
like
does the mechanism rely on like say compensatory increased blood flow? Is it the mechanism like
it's
the other?
it's it's called reperfusion syndrome. I haven't done it in quite some time, but or reperfusion injury.
Yeah.
If you're just curious, just look it up. And I may have got a few facts wrong, but
Mm-hmm.
essentially that's what it is, basically.